Welcome to AZIN's Guideline Updates, Episode G10, Pneumonia with Drug-Resistant Pathogens. I am Dr. Z, hospitalist attending, and KC is wrapping up the series with me. Educational only, not individual medical advice.
Dr. Z, I want to start with something real. When I see a pneumonia patient who looks sick or comes from a nursing home, my default is to go broad. Vancomycin plus piperacillin-tazobactam. Is that wrong?
It is one of the most common prescribing errors in hospital medicine. Multiple studies show empiric MRSA coverage is used in over 50% of patients who receive it without a validated indication. In the current guidelines, specifically the IDSA/ATS 2016 HAP/VAP guideline and the 2019 CAP guideline, give clear criteria for when that broad coverage is actually indicated.
What are those criteria for MRSA coverage and CAP?
Two specific risk factors from the 2019 ATS/IDSA CAP guideline: prior respiratory culture growing MRSA or hospitalization within the past 90 days plus receipt of intravenous antibiotics in that same period. That is it. Not nursing home residence, not chronic wounds, not dialysis. Those CAP era criteria are gone.
What about for HAP, hospital-acquired pneumonia?
The 2016 IDSA/ATS HAP/VAP guideline requires one of three. MRSA prevalence in the unit exceeds 20% for HAP or 10% for VAP. High risk for mortality, including mechanical ventilation or septic shock, or prior respiratory tract culture positive for MRSA. Without one of those, MRSA coverage empirically is not justified.
The MRSA nasal PCR. I have heard about this, but we do not always order it. What does it actually tell me?
The negative predictive value of a negative MRSA nasal PCR for MRSA pneumonia is above 95%. If you order it when you start vancomycin or linezolid, and the result comes back negative at 48 hours, and there is no MRSA in the respiratory cultures, you can discontinue the anti-MRSA agent with high confidence. That is a powerful de-escalation tool.
What if it is positive?
Positive MRSA nasal PCR has a positive predictive value of only about 40% for MRSA pneumonia. A positive swab does not confirm MRSA pneumonia. If the respiratory cultures do not grow MRSA, you can still de-escalate. The nasal PCR is primarily a rule-out tool, not a rule-in tool.
Vancomycin versus linezolid for MRSA pneumonia. Which one?
They are equivalent for MRSA pneumonia by the 2016 guideline. Linezolid has some data suggesting better lung tissue penetration, particularly for VAP. In practice, local preferences, cost, drug interactions, and tolerability guide the choice. Vancomycin requires monitoring for nephrotoxicity and needs AUC-guided dosing for optimal outcomes and safety. Linezolid interacts with serotonergic drugs and has bone marrow toxicity with prolonged use. Check your institutional antibiogram and consult pharmacy.
Pseudomonas. When do I need anti-pseudomonal coverage?
For CAP, prior respiratory culture growing Pseudomonas or advanced structural lung disease like bronchiectasis, or the same 90-day hospitalization plus 4 antibiotics criterion. For HAP, 2 or more anti-pseudomonal risk factors, structural lung disease, recent intravenous antibiotics, or high unit prevalence. The guideline explicitly says do not double cover for Pseudomonas empirically. One anti-pseudomonal agent is sufficient once you have culture data to work with.
Stable floor HAP patient. No MRSA history, no Pseudomonas history. What is the coverage?
Ceftriaxone. For a hemodynamically stable floor HAP patient without MRSA or Pseudomonas risk factors, ceftriaxone is reasonable empiric coverage. You do not need cefepime or piperacillin-tazobactam. Not all HAP requires broad coverage. The level of care and the patient risk profile determine the empiric regimen.
De-escalation. We talked about this in G3 for sepsis. It applies here too.
It applies here explicitly. The 2026 SSC guidelines we discussed in G3 now make de-escalation a strong recommendation. Cultures come back at 48 to 72 hours. Review them. If MRSA is not growing, stop vancomycin. If Pseudomonas is not growing, narrow to a non-antipseudomonal agent, if appropriate. If the gram stain shows gram-positive cocci and susceptibilities come back showing sensitivity to oxacillin, that is not MRSA. De-escalate.
Duration of therapy for HAP and VAP.
7 days of appropriate therapy for most HAP and VAP patients per the 2016 guideline, regardless of clinical response. Shorter courses are being studied for patients who respond rapidly, but 7 days remains the standard recommendation. For CAP, 5 days for non-severe, at least 5 days for severe, consistent with the 2025 ATS update we covered in G4.
I want to circle back to something.
The 2016 HAP/VAP guideline is 9 years old. Is that a limitation?
Yes, gram-negative resistance patterns have evolved significantly since 2016. Extended-spectrum beta-lactamases, carbapenem-resistant organisms, CRAB, which is carbapenem-resistant Acinetobacter baumannii. These are not well addressed in the 2016 guideline. A new HAP/VAP guideline update is anticipated but was not published as of May 2026. For unusual resistance patterns, consult infectious disease and check your local antibiogram. The 2016 guideline gives the framework. Local epidemiology fills the gaps.
Let me close the series. 3 take-homes from G10.
1. Before starting vancomycin or linezolid for pneumonia, document the specific risk factor. No risk factor means no indication. 2. Order the MRSA nasal PCR when you start anti-MRSA therapy and build a 48-hour de-escalation review into the plan. 3. Check the local antibiogram. Empiric decisions for HAP and VP are institution-specific.
And that closes the G3 to G10 series. Dr. Z, what is the thread across all 8 episodes?
Precision. Precision in antibiotic timing, in transfusion thresholds, in risk stratification for PE and GI bleeding, in de-escalation, in fluid choice. The theme of this series is that medicine is moving away from default orders and toward clinical reasoning applied to specific patients in specific situations. Guidelines are not recipes. They're frameworks for better thinking at the bedside.
Thank you, Dr. Z. This has been episodes G3 through G10 of AZENT's Guideline Updates.
Thank you to everyone listening. We will see you in the next series on AZENTS.